Good morning. Could I request everybody to please settle down so we may begin the session? Yes, sir. A very good morning to all of you. On behalf of Charutra Arogya Mandal and Bhai Kaka University, it is a privilege to invite all of you today, to welcome you all of you today on this 20th Shri H.M. Patel Memorial Lecture at Bhai Kaka Auditorium. This annual lecture series held in honor of our founder chairman, late Dr. H.M. Patel, whose vision for compassionate, high quality and affordable healthcare continues to guide all our institutions even today. As we begin this August morning, may I invite the dignitaries to kindly take their seats on the dais. I would request Dr. Jyoti Tiwari, Registrar, Bhai Kaka University, Dr. Abhay Dharamsi, Provost, Bhai Kaka University, Dr. Gauri Trivedi, President, Bhai Kaka University, our chief guest and speaker for today, Dr. Pavitra Mohan, Shri Amit Patel, Secretary, Charutra Arogya Mandal, and Shri Jagrut Bhatt, Member, Board of Governors, Bhai Kaka University, to please come forward and take their seats. I request the audience to please give them a warm round of applause. Could I request the people seated at the back to come forward, right? And because there's empty seats in the front. No, no. Of course. We begin this auspicious occasion with a moment of reflection and prayer, invoking the spirit of service and knowledge. May I request everybody to please stand up for the Sarv Dharm Pratna. As a tradition rooted in our culture, we light the Deep Shikha, the lamp of knowledge, to symbolize the dispelling of darkness and the illumination of minds. May I humbly invite the esteemed members on the dais to please come forward for the ceremonial lighting of the lamp. Ma'am, please. Asato ma sadgamayam, tamaso ma jyotirgamaya, mrityor ma amritam gamaya. From unreal, lead me to the real. From darkness, lead me to light. From death, lead me to immortality. Thank you, all our dignitaries. May this light continue to guide our collective journey towards equitable and compassionate healthcare. Charutar Arogya Mandal, we all know, was founded in 1972 as the realization of late Dr. H.M. Patel's dream to build a medical institution in rural Gujarat. It was his belief that students and professionals at the institution should not only be technically sound, but must also cultivate compassion, sensitivity, and ethics in their practice. This lecture series thus serves as an intellectual and ethical compass, inviting eminent national and international leaders to challenge the audience and reflect on our core purpose, to provide solace to the suffering, particularly to the poor and underprivileged in India's villages. Today is the 20th memorial lecture on equitable healthcare in India, leading the change. Continues that same tradition by focusing on how we can make quality healthcare truly reach the last mile. To formally welcome all of you and to set the context for today's deliberations, may I now invite Dr. Abhay Dharamsi, Provost Bhikhabhai University, to deliver the welcome address.
Good morning to all of you, distinguished guests, faculty, students, ladies and gentlemen. It is with great respect and deep honor that I welcome you all for this 20th H.M. Patel Memorial Lecture to celebrate and reflect on the life and legacy of Sri Hirubhai Muljibai Patel, affectionately called H.M., the founder chairman of Charutar Arogya Mandal, who envisioned building an institution that would offer modern healthcare to the rural community without any discrimination at affordable cost. Not only technically sound, but also sensitive to the needs of rural society. Today, we have come together not only to remember the extraordinary individual, but also one of the greatest son of the soil, Dr. H.M. Patel, and to continue a legacy of excellence, service and dedication that has inspired for generations. We are fortunate and honored to have amidst us Dr. Pavitra Mohan, who has kindly agreed to deliver today's lecture. Thank you, sir, for accepting our invitation and gracing the function. I also welcome Dr. Sanjana Mohan, who is accompanying Dr. Pavitra Mohan on this occasion. Thank you for coming. I extend a warm welcome to you. Dr. Pavitra Mohan is a pediatrician by profession with a master's degree in public health from the University of North Carolina, USA. His passion to community health culminated into organized efforts as the co-founder and executive director of Basic Healthcare Service, a startup not-for-profit organization based at Udaipur, Rajasthan. He is pursuing a vision of building a healthcare ecosystem that is rooted in the community, where the most vulnerable communities and can actually access high quality, low cost health with dignity. Dr. Mohan also serves as Director Health Services at Bhikhabhai, where he offers solutions to improve the healthcare of the families dependent on labor and migration. He has been affiliated with prestigious organizations like the UNICEF and WHO and has relentlessly worked to improve maternal, newborn and child health in India. We are reminded that the true measure of a life well lived is not just in what one accomplishes, but in lasting impact that leaves on the society. The work of Dr. H.M. Patel continues to inspire us, challenge us and motivate us to carry forward his mission. I extend my gratitude to all of you for being here today. Your presence is a testimony to the lasting influence of Dr. H.M. Patel and the continued relevance of his work. It is our shared responsibility to ensure that his spirit, not just in memory, but in the actions we take, the research we conduct, and the community we build. Thank you once again for coming here. Thank you.
Thank you very much, sir, for that warm welcome. And now the moment that we have all been looking forward to. A topic that touches every village, every family, equitable healthcare in India. And a speaker who has spent his life not only talking about equity, but building it, clinic by clinic, community by community. A pediatrician by training, a public health expert by conviction. His early associations with Earth in Rajasthan highlighted both the potential and the limits of existing primary care in India, right? Especially in the tribal and remote areas. Between 2004 to 2012, he joined the UNICEF, first at the Rajasthan State Office and then at the India Country Office in New Delhi, where he coordinated large-scale child health and health systems programs. He helped design and scale interventions such as the special care newborn units and integrated management of newborn and childhood illnesses, influencing policy and practice across multiple states. He was at the peak of his career. He had influence, he had comfort. लेकिन असली मोड़ तो January 2013 में आया. When most look forward to settle down, he chose to start up. He co-founded Basic Healthcare Services, BHS, with a non-negotiable principle. If the poor cannot pay, the cost must be ultra low, but the quality must be ultra high, which led to a network of Amrit clinics. A circle of care model was developed to address access, affordability and acceptability simultaneously. वो कहते हैं ना, कौन कहता है आसमां में सुराख नहीं हो सकता, एक पत्थर तो तबीयत से उछाल कर मारो. And that is what he did, right? And उसका नतीजा, his resolve transformed into a grassroots movement, delivering care to more than 4 lakh patient visits. A drastic reduction in severely underweight children at the Fulwadis, cut down from 29% to less than 6%. As a director of health services at Ajivika Bureau, leading programs to improve the health of migrant workers and their families who often fall through the cracks of conventional healthcare systems. He also co-founded Equitable Access to Healthcare, EHA Consortium, a collaborative platform to promote equitable healthcare and share learnings from grassroots organizations. He has been recognized as an Ashoka Fellow in 2019 for social entrepreneurship and a Community Service Award in 2024 for his services to the most vulnerable tribal and migrant families. And even while accepting these awards, his ethos reflected in his statement that this award belongs to the last mile worker because that's where the real work happens. An academic leader who has worked with institutions like the University of North Carolina, IIM Udaipur, and Academy of Family Physicians of India to strengthen primary care and train the next generation of physicians in rural India. A thought leader whose research and writings in leading national and international journals have consistently advocated for respectful, affordable, and decentralized healthcare. Another couplet by Majroo Sultanpuri fits so aptly. मैं अकेला ही चला था जानेबे मंजिल मगर लोग साथ आते गए और कानवा बनता गया. Ladies and gentlemen, please welcome the Executive Director of Basic Healthcare Services, the man who bridges the gap between University of North Carolina and the hamlets of South Rajasthan, the visionary leading the change, Dr. Pavitra Mohan.
Good morning, everyone. I think after a detailed introduction by Dr. Mustafa, I think my speech is over. He's probably practically told a lot about what I was going to say, but thank you for that generous and detailed introduction. I'll try not to repeat what he said. I'm really... Okay. And back. This one. Thank you. Good morning, everyone. I'm really indebted for the organizers for inviting me this morning for the 20th memorial lecture of in the memory of Dr. H.M. Patel, a nation builder who believed in solace for the suffering that has guided these institutions for all these years. And I was talking to someone saying that it's not easy for the institutions to remain value aligned for such a long time, and I think it is his legacy that has continued to keep the institutions so value aligned and service oriented for more than 40 years. So I'm really glad and privileged to be here this morning. I will today speak about an issue that is, of course, very close to my heart and is also probably at the center of any just society. Right? I mean, a just society is one where everybody has the same opportunities for optimizing their potential in terms of health, growth, development, and livelihoods. And a society that is not able to ensure that equitable access to healthcare, to education, to basic conditions of living is, more needs to be done in able to ensure justice. So it's at the center, it's at a very core of a society to have equitable healthcare. There are many definitions of inequity in health, but the one that I really like is this. It is fairly simple. It just says that there are disparities which are unfair and which are systematic. So it's not by a matter of chance or by biology or genetics that there are differences among groups of populations or among people. It is because it is unjust allocation of resources or access to care, and it is systematic. So this is a simple definition that I quite like. If we look at India, of course, many of us in this room know that there are huge disparities in India in terms of access to health. I would take a few examples to drive home a point, and I'm sure you would know probably many more. In a city, rich people who have access to a private hospital can get the state-of-the-art care at whatever cost it comes. And I was in a convocation of a management school institution where a CEO of a large hospital said that we have reduced the waiting time from door to the OT, door to the table, from 30 minutes to 28 minutes or something. And here I was wondering that a young person in South Rajasthan takes almost 6 months from the initiation of symptoms when he starts coughing and spitting blood to actually seeking treatment. So that's the kind of difference or disparities that we see. There is also, we often talk of in terms of tribal populations and access to care. We say that sickle cell anemia is a huge problem, right? And which is genetic, which you can't do anything about it. You can probably prevent it, you can screen it, and therefore reduce it and provide care. But the prevalence of sickle cell per se is genetic in nature. But what we see, for example, in our area is that women with hemoglobin as low as 3 to 4 grams visit our clinics, some 4 to 5 women every week, which is predominantly nutritional anemia, right? That cannot be explained by genetics. That is, there's something else happening here. And when we try to find out what is that something else that is causing, I mean, in a city, if a person walks in with 3 to 4 grams of hemoglobin, you would put him in an ICU. And here these women come walking and go back walking 6 to 7 kilometers over the hills. We tried to find out what is the reason, and we found that there is huge lack of access to food in many of these communities that we're working with. For example, in a study that we also published subsequently and built some of our programs around it, we found that less than half of women who have children less than 5 years had eaten any vegetables or pulses in last 4 hours. And here, if you just juxtapose it to what we eat during pregnancy or childbirth or in early child rearing period, these disparities become really stark. Right? Many men from the areas that we work in migrate to cities like Ahmedabad, Mumbai, Surat, because there are very limited employment opportunities. Over years, the farm sizes have become small, and people need to migrate to sustain their livelihoods. Many of them as young as 16, 17, 18 years. And within a few years, because of exposure to dust and smoke, they get, and living in crowded conditions, they develop tuberculosis, and many of them come back and then present at our clinics. So a life very early, affected by disease and by disease and disability. So, is that how we would envisage our children and our people in our families to have the exposure to such hazardous dust and smoke and other injuries at that age? So, the point I'm making is that there are huge disparities that persist. Overall, as a nation, we have grown, our mortalities have grown, but inequities cannot be only looked at by averages. Averages hide the truth hugely. And when we look at these populations, which are also not small in number, when we started working in South Rajasthan, I then started looking around. Are we in some very typical, very most underprivileged areas? Are we very peculiar? And then when we looked around, whether it was in Chhattisgarh or Jharkhand or Orissa, or even in remote areas of Tamil Nadu, we found that there are similar populations. And a broad estimate that I've come to is that roughly 25 crore people in this country live in somewhat similar situations. There can be variations, but there are huge sets of populations that continue to be affected by inadequate access to healthcare and food. So while this is clear, I would like to make another point which sometimes is given as an argument about the genetics being different, and therefore these differences. So I'd like to bring your attention to these two graphs. The first one on the left is the growth curves of children in our communities among 500 children, where you see that children in the red, in the first graph, if you just concentrate on the left graph and look at the red graph, the whole population is shifted to the left, which means that the entire children are much below the standards of the reference curve. The reference curve is the green one, which means that children who are well nourished and they have access to food, etc. That's the green one, and the red one are those in our population, which means that the entire population is shifted to the left, which means that we are missing, as a nation, we are missing a lot of growth potential, and as an individual, there is something wrong that we are not able to ensure equal growth opportunities to everyone. Now, people say that this is genetic. Indian children are shorter, tribal children are genetically shorter, and that's where I will like to bring your attention to the second graph. These are children from 5 different countries, right? From Norway, from India, from Africa. And if you look at these growth curves, what do you see? They are absolutely overlapping. There's no difference in growth potential of children in India or in Norway or in America or in Africa, because the difference is that all these children were from affluent families. For example, in India, these were children from New Delhi who had access to food and care, etc. And they grow as well as children in America. So there is no genetic theory going around here. It's because there is differential access to food, etc., which over years translate into equal growth if everybody is given a fair deal. Okay, so what do we do about it? We can say that, you know, governments are responsible, my neighbors are responsible, America is responsible, Trump is responsible, and so on. Yeah. So Lily Tomlin is a, I don't know if some of you know, she's an actress and a comedian, is a Grammy and Emmy Award winner. And this is something that struck me. It was actually one of, I mean, not one, we have only one son. So my son actually posted it some time back, and I found this quite striking. She said that, you know, I was thinking that somebody should do something about it. That we often say, कि किसी को तो करना चाहिए. Somebody needs to break this inequity. Somebody needs to do something about it. Till you, when you look around and you go behind and front and right and left, you realize that who is that somebody? It's me, right? And that's where the power starts from, right? I mean, if you realize that you are the one who has to do something, whatever little, whatever more, whether it will succeed, not succeed, doesn't matter. But if you feel that I am also in some ways responsible, that's where the change starts. Stephen Covey, many of you would have known of him, very acclaimed book called 7 Habits of Highly Effective People. If you haven't, it's very strongly recommended. He's gleaned teachings from many, many writers, philosophers of last 1 or 2 centuries. And one of the central piece that I like about that book is that when he defines responsibility, he said responsibility means the ability to respond, right? It is, so what do you respond to? In this context, we are saying respond to the inequities that exist. How do you respond to it is, do you have that ability, or can you create, or can you draw on that ability to respond to the, again, inside out, start from yourself, right? How can you think of it from that lens? Right? And of course, Mahatma Gandhi, everybody must have heard of this, that be the change you want to see. If you want to see a change, either you don't want to see the change, that's also fine. One can live as an ostrich or as a, or even decide that that's fine. We can live with these inequities. We can, fend after ourselves. That's also fine. But if you decide to do something, then you have to be the change yourself. You can't expect others around you or the governments or the politicians or whoever else to be the change. It may be small, it may be inadequate, it may not succeed, but that's fine as long as you realize that you have an ability to respond. That's an innate ability which nobody can really rob you of. You know, in fact, in this book, Stephen Covey also talks of Viktor Frankl, who was a philosopher, who was a psychiatrist, and as a Jew, he was in concentration camps, where he said that the last ability is to respond. How do you respond to an adverse situation is among the last of your free will that remains, even when you're in a concentration camp. So that kind of sets some stage to say that where can the change begin from, potentially. Many of you may know Dr. M.K. Bhan in this room. He was a pediatrician, professor at All India Institute of Medical Sciences in Delhi, then went on to become Secretary of Biotechnology and one of the foremost scientists that India has produced in the medical sciences. He also kind of discovered rotavirus vaccine and many others, zinc and dairy, many other. So I had a opportunity and of his counsel and advice in my growing years, and I was in as Dr. Mustafa has already detailed out that Sanya and I were working in R&T Medical College, and one of the things that I was getting restless was, one of the reasons for going to R&T Medical College in Udaipur from Delhi was to understand rural communities a bit better, being a bit closer. But I was getting restless working in the hospital, seeing children with measles coming and dying, or a severely malnourished child coming and then getting better, but knowing I knew instinctively that this child will go back, eat the same food, will have the same lack of care and would come back to the hospital next month. So that's the kind of thoughts I was having, and so I went to Dr. Bhan and I went to Delhi. I took a overnight bus from Udaipur and went to him and asked him that what should I do, I want to work with the community. He said, look, you have no skills in working with communities, go and get yourself trained first. I didn't understand fully. I said, I'm a pediatrician, I'm already teaching, so why do I need to? But then that really transformed. It was a advice that I took seriously. And then went on to study public health. And on coming back, I led a large trial working with health systems on seeing how counseling affects care-seeking behavior. It was a complex randomized trial working with health systems. But more than that study per se, there was a side study, that side analysis that we did, which is a fairly simple analysis. We tried to see that what are the determinants of immunization coverage among populations that we were surveying. And we found that distance plays a huge role in immunization coverage. People who live far are much likely to be immunized than people who live closer to the sub-centers or to primary health centers. A very simple logic, of course, if you're closer, but in these areas where distances play such a huge role, absence of vehicles, limited autonomy of women to travel with children, if you're very far, you would get less services than when you're closer by. So based on this study, I subsequently joined UNICEF and created a program, immunization program, where we said that let's have then, if distance is a problem, let's have vaccination as close to people as possible. And we had a cutoff of half an hour of travel. We said, if let's micro plan for each and every village in the state to see that where can the immunization session be, so that women don't have to travel more than 30 minutes. That was the criteria we set up, including the smallest villages, which we used to call as C-type villages then. And that program led to significant increase over next 4 years, led to significant increase in almost doubling of immunization coverage in 4 years, including in the farthest of the hamlets. So that kind of gave me an insight of what is possible, right? I mean, with the right knowledge and ground insight, and then right opportunities to be able to influence a program, led to a significant increase. My first kind of an experience of making a significant change at a large level of promoting equitable kind of coverage. Fast forward, and I was in, as Dr. Mustafa said, I was working with UNICEF India. Besides other things, it gave me an opportunity to travel to the remotest parts of the country. I would visit different states. And what I would make sure is to go to the remotest of the districts and the blocks and see what is happening there. Because while we were very excited at what we were doing, but I didn't know what is happening in the more impoverished and difficult blocks. And this is what I saw, that there are geographic areas which are uncovered, inaccessible, and people are largely left to fend for themselves when it comes to healthcare. But I was also not naive by that time. I also knew that it is not easy to provide healthcare in such locations, because who provides care? How do you live there? How do you transport drugs, vaccines? How do you build infrastructure? And therefore, there were no easy answers. So that is the time when we decided, Sanjana and some of our colleagues decided, let's do something about it. And again, coming back to that, there were no easy answers, so let's do it ourselves. So that's when I quit UNICEF, and we co-founded Basic Healthcare Services and started working in remote areas of South Rajasthan. I had already lived and worked in South Rajasthan, so we had friends and networks, and there is of course a huge need. It's a highly impoverished area with a lot of difficult terrains and generally a poor public health system. So that's where we started building what we then called as Amrit clinics. So the idea was very simple. The idea was that, one, it was based on the understanding that poor need healthcare as much as rich do, and they need the same quality of care as others do. So you can't really say that poor deserve poor healthcare. So can you build something like this? The other principle was basically the principles of primary healthcare, which means that the services have to be really close to the communities. They have to be with the participation of the communities. They have to be accessible and use kind of whatever best evidence and technology you have at your disposal to provide that care. So those were some of the basic principles that we started with. The other principle, so what you see here is the first Amrit clinic in its early days. The building that you see is small. It is donated by the, not really donated, but leased out by the panchayat for a long period of time. So that kind of starts ensuring some community participation from the beginning, rather than going and building a greenfield clinic. Nurses are at the center of these clinics. We were having some discussion in the morning about the team requirement of teams, and doctors are often placed at the hierarchy of healthcare, but in principle, nurses, health workers, play a huge role, and when you need to decentralize care, we started with the assumption that doctors won't be available, so while there will be a doctor, but nurses would play a larger role. But later on we found that actually nurses are the right fit. They come from the similar communities, it's easier for them to communicate, and with suitable training, job aids and support with visiting physician, that can really and these nurses often, I'm sure you would be seeing that in last 20 years there has been a lot of production of nurses, even from the deepest tribal areas. So those girls can then go back and work in these clinics. So maybe I'll just briefly show you a small video if I can. Can you just play this? Yeah. Which shows again the early days of the clinic, the first clinic that we had said, first two. Yeah. Wanted to give you a glimpse of what it looks like. So this is what it looks like, and one, yeah, that's fine. You can, man, next. I'll probably just stay here. Yeah. So I just remembered that the person that you, woman that you saw being lifted, she had severe rheumatoid arthritis for last 10 years, and she was untreated, and just because of rheumatoid arthritis, she was lying in the bed, could not perform any function, and she was carried by her husband. And today she comes walking to the clinic and has started cooking. And the first day she said that I've started cooking, and now she walks up without, on her own, climbs up the hills, etc. So that's the power of care that is closer to people. It is not that care, it's not a scientific advance. We know that rheumatoid arthritis can be treated with simple medication, but just absence of it. For a person, the nearest health facility from there would be probably 100 kilometers where she would have got a treatment for rheumatoid arthritis. But in absence of that, she remained untreated for all these years. So that's the kind of power of being services that are closer, that respond to people's needs, and that is evidence-based. Since then, the clinics have grown. We run about we run 6 such clinics covering about 100,000 population in similar areas across Udaipur and Dungarpur districts. There has also been a growth in nurse-led models across the country. Many organizations and governments are investing much more on nurses to provide comprehensive care close by. The clinics provide care for a wide range of conditions and comprehensiveness that is so critical, especially in rural settings. You can't be specialized there. You need to provide care for what people need. These clinics provide, for example, care for low birth weight babies at the community level. They treat children with severe acute malnutrition, provide care for tuberculosis. For elderly, they provide care for diabetes, hypertension, chronic lung diseases, and for last year or so, also for severe mental illnesses. The clinics also manage epidemics of diarrhea and malaria, which are common feature in those areas. With intervention, they stop for a few years and then come back with a vengeance. They also empower, educate, and organize communities to own up their own health. And in many cases, link families with social support. For example, many people with tuberculosis, even after treatment, just don't have the capacity to go back and perform heavy manual work. So that's where we link them with skills where they can do either a small shop or can do alternative, less labor intensive services. Um, Still, all of that still doesn't, don't understand how does it affect families. I would just like to share a two stories here of how the care which is closer to people impact lives. Start with the one on the right where you see a woman whose face is hidden for privacy reasons. This was a person who had been severely mental ill for almost 10 years, and she had been wandering around, and she would sleep in the forest every night. She would not come back home. The mother would go and in the day would talk to her, but then she would go back to the and in absence of a care for psychiatric illness, which was in this case schizophrenia, uh, she would continue to be walking around. Her husband had left her. When one of our field workers who come from the same community identified her, took our mental health professionals, some of us went and sat with her, talked to her, identified what potential condition is, build some trust. So 3-4 visits were there only for building that trust at a community. This was not at the clinic. And then, when we had enough trust, started medication. And after a month or so, she for the first time came out. And after 2 months, she started sleeping back in her home, and now kind of performs household chores and lives, in her home, and the family is taking care of. Of course, the care which is closer home, which is not bound by the boundaries of the clinic, that only if somebody comes would be treat, understand what is the right way of managing her. And of course, in this case and in many other such cases, family support is extremely crucial. In this case, the mother was very, very loving and took care of her. So this is another thing I would like to highlight, that many times we think that families in rural areas don't care for their children adequately as much as we in the cities do, but their love and affection is often as strong. Sometimes it's broken because of their daily chores and difficulties in their daily lives, but in this case, the mother was also the one on the left, it's a picture changed again for privacy reasons. This is not the person I'm talking about, but it represents a woman from the community who, in early days of our clinic, came to a clinic for some respiratory illnesses. She was in respiratory distress. Our nurses were there. They called up, managed the respiratory infection. We started her on antibiotics. She was found to be HIV positive and tuberculosis. Her children were unfortunately also found to be HIV positive. The husband had left her. Husband was a migrant. He was a driver in some area. He had already abandoned her, and she was living with her parents. So we started again building trust, starting treatment. It took quite a few months to finally get her back, link her to antiretroviral treatment, anti-tuberculosis treatment. Children were identified and treated. And I'm really glad to say that she's now a community health worker who provides healthcare to a lot of people in her area with such conviction. She has such confidence now. She talks to MLA as if, she can raise issues of her community in front of the MLA. Her children are doing well. They are in school, in a hostel. So all that is possible just because we are there and on a day-to-day basis, and there is an understanding and trust with the communities and some ownership. So that was, the second kind of a snapshot that I shared. I shared about the immunization program at a meta level, then working on setting up Amrit clinics, looking at a specific problem. The other problem we were seeing in these areas was huge levels of malnutrition, which as pediatricians it was not new to us. But what was new to us was that even adults were malnourished, and that could not be ascribed to only practices. In having worked in UNICEF, a big focus has been on saying that malnutrition is because of poor feeding practices, right? And if you educate, improve those, that should improve. But what we were finding when we started discovering it, we found that there's a huge lack of access to food, availability of food. If you look at this graph, only some pulses were available in only less than half of the households, right? Vegetables in less than 15% of households. So there was a clear lack of access to food that we were seeing, and that probably was explaining the high levels of malnutrition. There was also lack of time mothers had. They get up very early in the morning, go to collect firewoods for 3-4 hours, come back, and then tend for animals. Husbands are not there, they are in Ahmedabad or Surat. So that puts a lot of time pressure, and children are largely left to fend for themselves. They're roaming around. Mothers are also often concerned that their children would be trampled by an animal, or who would take care. Sometimes the elderly do take care if they are able, but many times they are not able, and therefore, so that was another problem that was staring at our face. And we said, okay, we can't, and there are large number of such, and we said we can't do probably something for everything, but can we set up some daycare centers where children are provided care and food and stimulation? We had seen similar work being done in JSS in Chhattisgarh, and we said this is exactly what we require here. And so we right now run about 18 of such daycare centers, each enrolling about 20 children. It's a joy to see such children who otherwise at home would be just loitering around, not eating through the day, or always in the fear of being trampled by animals or falling in the well, being cared for, growing very well. Many of them have now graduated, gone to schools, doing extremely well in schools. You know, the teachers come back and say that this child is exceptionally bright. Where has he come from? And you know, so all that is possible. It's the first graph, if you remember. All these children have the same potential, right, as any of our children. The problem has been opportunities, and this was our small contribution to say we still probably cover 10% of the children, even in our own area. Forget about the rest of state. And but it is a model that's gaining traction. Government has started what they call as a Palna scheme, which is to convert many of the Anganwadis into daycare centers. Azim Premji Foundation is setting up some 10,000 such daycare centers across different states. So the idea has caught up. It just needs to multiply. There is no other way that children where parents are not able to take care for various economic and social reasons, there needs to be some care where they can optimize their potential. Last of the some examples where a change was possible was that you know, many of us have been talking about Right to Health Act in the country. The National Health Policy of 2017 said that no, we can't have Right to Health Act for the entire country, but the states are free to do so. That's where in Rajasthan, some of us in the civil society space got together and had been working with the government. And finally, 2 years back, a law was enacted. You know, for us, it was a big victory, not because what it changes on the ground, probably not much, but what it changes is that a clear recognition in the preamble of the act, which says that governments are responsible for healthcare of the population, and inequities exist for which we would continue to ensure that there is affordable, there is free treatment for all in all public facilities. So in the current discourse where there's a lot of talk of privatization of primary health care, of secondary health care, this came as a bit of a constitutional framework under which people can be treated with dignity, and not only healthcare, not as a dole, but as a right. So that's about 2 years back it kind of got enacted. We still are fighting for the rules. There are still no rules of the act, but in principle at least there is a constitutional obligation on the government to ensure that there is free and quality healthcare for everyone. Rajasthan has become the first state in the country to have enacted this. While doing all of it, it's not a, I mean, we were talking in the morning that what does it give you, right? I mean, I think we receive much more than what we can ever contribute in these communities. You find many people whose wisdom, even if they are not educated, they speak words of wisdom that no educated person can ever utter. We find companies of such people. We learn a lot from our younger colleagues who work with us. They go on to do amazing things, either with us or in other places. So we are absolutely grateful for, you know, for having this opportunity to work with communities and to bring about some change in whatever little manner that is possible. We continue to find ways to do more, but the force multiply with others, especially with our younger colleagues who we find that we are able to provide some harbor to them to optimize what they have been thinking about, their values, their own desire and dreams to make a change, is provided some space here in our organization. And, so of course, all of you are familiar with Sardar Patel. We are sitting here in his where he lived and breathed. And so he actually, I think this was probably 1924 or something, when he said that we must remove distinctions of high and low, rich and poor, caste or creed. What we know is that it is still not a reality in India in respect to healthcare and probably in other domains as well. And we need to, you know, see where can we then come in and make a difference. It continues to be, you know, what we call as a lottery of birth, where you are born still determines how you would grow in. So this is where we are right now. But the good news is that we can make a change. Right? I mean, we can make a change, and that change can begin with ourselves. And my experience has been that that change, as an individual, as a professional, it is also very joyous and fulfilling. Many times we say, oh, when people say, oh, you are doing this work and that, I said, this is what really gives us joy. It gives us fulfillment, also professional fulfillment, and a life that is rich. We meet with good people, we work with great communities. So all of it is also joyous. So while we, and this is where I think many of you would be familiar with this song. Actually, Sham had first shared it with us some time back. Um, I don't know whether it's correct or not. In Gujarati, it's called Gamto Ne Kariye, spread good with joy. So that is, towards the end, I would like to say that this journey is joyous. Anybody who wishes to work closer to communities, work with communities, or work on reducing these inequities in whichever way they can, it is a joyous path. And one of our younger colleagues made this video to say that how do we envision a more equitable and a just society. So it's a small, can you just play this? Oh, okay. आगे लास्ट में yes इसको प्ले कर सकते हैं. It just shows how joyous and an equitable society look like. Thank you very much. I'd be happy to answer any questions or comments.
Anybody from the audience would want?
I think she wanted to ask.
Sir, how do you tie up with government in your programs? Because sometimes tying up with government may delay the things a lot. So, how do you do that?
So, you know, I mean, there are many ways of answering this question of what exactly, how do we work with government? But the point is that I think if we are determined to make a change in the community and whatever it takes and whoever it takes to work with, you need to work with them, right? I mean, government has a large mandate. I mean, it has the sole mandate actually of ensuring healthcare. So one works with them, but in practical terms, there are always challenges. There are fights. There is love-hate relationship. But there are many times when we have done great work with the government. For example, this whole Right to Health Act would not be possible without having worked closely with the government. But there are times when they ask us not to report tuberculosis because the numbers are growing too large. They said you are doing something wrong with the sputum because you're mixing sputum. That's why we don't have such high levels of tuberculosis. So all that happens. But I think if you're determined that who is at the center, the center is communities, then you face all of it to work with.
I have, sir, 2-3 questions. Sir, first thing that, as you mentioned about that lack of the food, the quality healthy food was one of the major reason. Now, as a professional, as a doctor, it is a non-health portion of ensuring a health. So, how did you overcome that issue?
Thank you for asking. I think a lot of health is non-health,
yes,
non-medical, so to say. But I think again, professional being a doctor, being a professional is one part of your identity. You know, as a citizen, you have many other roles to play. So you begin with being a doctor because that's what give you privilege, that's what give you courage and resources and credibility in the community. But then you leverage everything else you have, work with others, understand better. For example, in this case, one of the things we have done, which we have not shared, is to work with another organization that has excellent skills in growing food and vegetables. But they did it from a livelihood perspective. For them, they didn't understand nutrition. They felt that they can grow vegetable and food and they can sell it. So we have collaborated for last 2-3 years, helping small farmers to grow food and consume it themselves before selling it. So I think if you are concerned about a problem, you again do whatever it takes. Yes. Expand your horizon. Don't be limited by your professional identity of being a doctor. Right. Otherwise, we'll remain within our four walls and doing what we do. Change would require more than you can either expand your own skills, but often you would need to collaborate with others too.
Right. If I'm permitted, can I ask another 2 questions? Okay, sir. Another thing that, as you mentioned, 6 Amrit clinics and 18 daycare centers. Now, any other specific community health programs where it is something delivered as a doorstep other than this Amrit clinic?
So Amrit clinics are the kind of a brand identity where the
Right.
curative care comes, and as I was speaking to someone in the morning, that curative care helps you get a full load in the community because it relieves your immediate needs of the community. But health requires much more than that. So a lot of work that we do with communities is beyond those 4 walls. It includes a very large tuberculosis program that we are working with the communities. It's a large kind of advocacy and work on silicosis that we are doing because we see a lot of stone carving workers getting affected with silicosis at a very young age. So that requires a different approach altogether. So we don't look at a project a priori when we are encountering an issue, then what is the best way to address it? Is it through clinical care or in outreach? But the clinical care is important in understanding the communities, responding to their immediate needs, which is in itself an important and a critical component.
Right. The third thing is availability of the qualified doctors at the remote areas. That is the biggest challenge. I think you mentioned, sir, something about that on a visiting basis or something. So any other solution could you find out?
So India is producing 100,000 doctors every year, right? And and probably some 600,000-700,000 nurses every year. So what we believe is that again, even curative care is not only a doctor's domain. We can find out innovative solutions. What we do is we believe a lot in nurses for primary health care, and they can be trained and supported with many means, with technology, with trainings and other ways to provide good quality evidence-based care to meet something like 70-80% of the needs of populations we serve. Working and telemedicine is often hyped as something that's very complicated. Just picking up a phone and ability to talk to someone who understands the problems and understands the community is a way to again empower the frontline health workers of different kind. We believe in nurses because there is also a regulatory framework around it, and they can move up the career path. The future lies, to my mind, a lot of future of rural healthcare and primary healthcare lies in nurses.
True.
But that's a different discussion.
Thank you very much.
So access to hygienic and nutritious food is a problem in nutrition, malnutrition, anemia. But there is a large group of people where it is not a problem, but the problem is in the feeding practices. So what is your experience in bringing the behavior change?
No, thank you for that question. So, I think when we talk of behaviors, ma'am, there are behaviors that our forefathers practiced and which we have given up because of access to modern information, knowledge, services. So our experience has been that providing consistent services, messaging, and understanding where their behavior is coming from. I'll give you an example. When we started the Fulvaris, we provide an egg to provide high quality protein. It's very difficult to provide high quality protein at a cheap rate for for children except for an egg. You can provide milk, etc. In these areas, there is very little milk available, and shelf life is a problem. In the beginning, we were told that children don't eat egg here. Women don't eat eggs at all because they say that it's a life, there is a life in, and therefore, and even if it is a sterilized egg, they would not eat, and children are not given egg. And we said we tried different things, but then when we started understanding, we realized that broadly at a family level, they had no problem with giving eggs. It was only for a specific age of children that there was a problem. So when we started talking to them, negotiating, understanding, and we said, okay, let's start giving it in Fulvaris. Now, almost in no Fulvaris is anybody ever, and children just love it. They kept it, families don't respond to it. So it takes time, but I think a consistent effort, and it's a both ways negotiation, you know. There are about 10% of tribal families, I am sure yahan par bhi hoga, who are called Bhagats, where for religious reasons they don't eat eggs. So there we don't push them too hard. But in others where traditionally they had been eating eggs, but only because of a misconception that they had, stopped giving. So broadly, how we look at behaviors is that there are desirable behaviors that families practice. For example, breastfeeding rates among tribals are highest in the country, right? And nobody has taught them that you must give breast milk. In cities, we keep telling mothers you give breastfeed, but they would give an alternate. In tribal families, so that's a desirable practice. So we tend to promote those practices which are desirable. Then there are some which are absolutely harmful, like branding. You continue to brand children when they are ill. That is an undesirable, dangerous practice which we then take heads on with the communities and say that this is wrong. And then there are some which are in between where you don't matter. Let them practice if they do something that is not desirable. So behavior change, I think, requires one is it requires time because it is hundreds and centuries of certain kinds of practicing. We have changed. I mean, if you just think about your own grandparents or your parents, you would find several practices which today you would consider superstitious or wrong, or in 2 generations that change has happened. So there also we can't wait for that time. Can we fast track it by providing the right information, by bridging this information gap? We can. I think that's a
as this image says, Gamtano Kariye Gulal. I think it is roughly inherent in all the people. That is why whenever there is some good message in the WhatsApp, most of them try to forward. On the serious note, as I said in morning, I am an ophthalmologist, and we have a habit of practice of doing eye camps. But since many years, we have seen that the result is not what we wanted. There are no very less patients are coming. So do you have any suggestion or guidance for how to increase the eye camp patients in our area?
I would need to know more about the area and understand that a bit more. But what I know is that I think we have to find out the need. Sometimes the need is not very manifest. We may be hitting in the wrong area, or there may be certain barriers in people's minds that maybe somebody's eyes had got damaged when they came here, and that's news has spread. So I think we have to understand what the needs are huge. I mean, you also know that there is so much of blindness which is avoidable because of cataract. In our areas, we now get 60-70 patients on a given day when we want, and they all get operated, which we don't operate, but we have tied up with the hospital. So, and again, there are areas where there are very few people who come forward. So we have to just see, is the problem, is there a less need, or is there some hidden failure, or is there hidden access problem? I think once we become responsible, that we are responsible for this block to completely eradicate the avoidable blindness, that is when you will start finding out the right way to reaching out. If we just keep waiting, ki theek hai, anybody who comes, that's fine, that's good enough, that's also good enough. But if we are responsible for a population, we have to find out the reasons why people are not coming despite. There can be many different reasons.
Hello, sir. Since we are in a university and there are a lot of medical students around, it would be useful if you can just share about the RSP work and your experiences and take.
So for some of those medical students and young doctors who wish to experience rural healthcare, understand more about it, understand the problems as well as potential solutions, and get inspired by some of the community health workers and people themselves, then we and a group of organizations run a 3 to 4 day residential program called Rural Sensitization Program, where young doctors as well as medical students and public health students as well, physiotherapists, they're welcome to apply. We do it in November or October every year. Usually we try to do it around October 2nd. So yeah, you're welcome to apply and participate in that. In many places, at the end of the 3 days, many people feel quite transformed, reflective. Of course, some of them then carry it through their lives. Some of them go back and get into their route. But it is a worthwhile thing to spend 3 days there to understand what the reality is and to, make visible what is often remains invisible for many of the doctors and medical students. So you're absolutely welcome to apply. We normally advertise it in the.
Good morning, sir. I have some personal question actually. So in young age, everybody has some financial goal, family goal. So how do you, or when you have in your mind that you should go ahead with this community field work, and how you have managed with the family as well as yourself, sir? Thank you.
Thank you for asking this question. I think it's a. So there are again two ways of looking at it. One is that, if you look at, if I look at my experience or people, others' experience, in general, I feel that as a doctor, once you've completed your education and you're a medical doctor, often life gives you enough to sustain and sustain well, right? That's one way of looking at it. The second is that, of course, you need to earn money and you need to have a family, but the value of money decreases exponentially as you go. There is a sweet spot which comes where growth, what is your goals in life? Money helps you up to a certain point in achieving your life goals. Beyond that, it can be a distractor. Does it help you to grow? For example, a lot of us, including Dr. Shyam Sundar sitting here, travel a lot. They go to multiple places. It gives you that flexibility. You meet with people, which makes you grow. You take up difficult challenges with the communities, which makes you grow. So there are, you are closer to the nature. You are not in a city with an AQI of 500. That also gives you, a longer and a better quality of life. So I think a good life is not only I'm not saying that money is not important, but money is only important up to a point, and that one has to be careful about. Sometimes you overshoot and continue to go on a path, while other benefits of life, which life has to offer, money becomes an important thing in itself. So as long as it is a means to achieve a good life, till that point it's good. And I think many of those who are sitting here would vouch for it. That look at what other thing life has to offer. There are several goals, and money is an important, but it's like a hygiene factor. You need to have it to ensure that you go along in life. People don't question you. But there are many other things that come with doing things that are closer to your heart, that gives you joy, that gives you exposure to different realities of the world, address some of the critical problems. So just balancing act.
Sir, do you have any holistic care programs for, say, pregnant women or children? In a way, it is in some way continuation of what he said, that money and hunger matters, but then the life doesn't stop there. And the religious and cultural beliefs, they can contribute very heavily in making positive change in the health and everything.
You're right. I think ultimately the values that you grow up with are important. But I think Gandhiji had said that in a democratic, in a empty stomach cannot sustain democracy, right? If there are people who are hungry, it cannot sustain democracy. So I think we have chosen that path to say that can we meet the basic needs which allow people to then, manifest other things. And the other is by demonstration. If, another of our advisor, a very wise person, often says that what the change that you want to see in the community or the values you want to see, you have to practice it within your organization first. So to be able to do that, have a democratic organization, a service-oriented organization, a learning organization is important, and only then that it can transfer into the community. So I think trying to instill values directly into the community is something we have not thought of except for as a demonstration and except for as a service. So I think if people's basic needs are taken care of, and again, I think we are actually no one to instill values. As I was saying, probably I did not say it clearly enough, that I have actually learned so much. There is a person who is, this community health worker that I was talking of, the woman with HIV. She's demonstrating it with her life of how, despite being so constrained, she had infection at a young age, separated, 2 children to take care of. What other value can you demonstrate? So I think we have a lot to learn from people themselves. So those values are there. They are sometimes they are inhibited because of the day-to-day constraints or not being able to meet the basic needs. So if we can do that, I think other things will take care of themselves. We have enough wisdom within the communities and society and whatever else has been guiding us through the centuries to take care of it. We probably need not instill external values except for by demonstration of.
Sir, good morning, sir. Sir, as far as care of newborn is concerned, I would like to know from you that which are the interventions which would have worked best for the care of newborn and young infants, as per your experience. Because we work in tertiary care hospital, we may not have that kind of exposure to primary care, but definitely we do a lot for primary care. But I want your experience, how it has helped.
Have a very long conversation on it, and maybe we can do that separately, because it's again an area which is very close to my heart, and I've worked a lot on newborn care. But I think from the standpoint of the communities that we work with, what has worked the best? So I think again, when we look at newborn care, there are several aspects. It starts from the mother's well-being, etc. Right? If, for example, I often say that birth spacing is one of the biggest intervention for newborn survival. If there is equal spacing, it is. And we have done some modeling that if you space enough, you actually need to do very little else to reduce neonatal mortality. There are other factors, for example, Sanjana led a trial where they looked at oxytocin misuse, and if that was to be reduced or removed, it would save some 200,000 newborns a year. Right? So just a misuse of a medical intervention, that itself will reduce. So I think, so some of those things we need to understand. But if you are specifically looking at after the baby is born and how do you provide care, to my mind, based on my own experience, both in a tertiary hospital where I worked in newborn units, and then we helped set up newborn care units across the country, simple interventions work the best. In fact, in the nursery in Safdarjung Hospital, where I started my career in residency and then senior residency, just by ensuring that mothers stay with the babies and by hand washing, we reduced the mortality in the nursery. At that time was 40%. We reduced it to 5%. Within a 2 months' time, just temperature, feeding, and hand washing, 3 things, And KMC is a beautiful, beautiful intervention because it empowers women. It is evidence-based. It doesn't require anybody else. So I think simple things really help newborns. They are really very resilient. They need very little. They just need right temperature, feeding, and prevention from infections, mother's warmth to. In most cases, that's what is really required as far as care is concerned. But if you look at overall determinants, then I would say spacing is a very, very critical intervention, and so is misuse of oxytocin.
So, were these, like thinking about social equity, these traits were there since childhood, or you had a family background like that which led you to this path? You also took up pediatrics. So, can you elaborate?
So, to some extent, yes. My grandfather was a freedom fighter. He worked alongside Gandhi, and he was in Sabarmati Ashram, etc. So, we had some family discourse around it and discussions from early on. But one significant factor that influenced my thinking was that Wardha, when I was preparing for Wardha medical entrance examination, while preparing for PMT in other places, and you have to read Gandhian thoughts as a separate course. You need to clear that to be able to consider. And that's the time when I first time read Gandhi's autobiography and a few of his other books that were essential readings. That kind of, I think, helped consolidate some of those thoughts early on. And then it was kind of progressive that.
Thank you so much, sir, for sharing your wonderful life journey. It was really very inspiring to go through the impact that you have made. So I just wanted to know if there were certain phases in this journey where you felt like giving up, and what sustained you.
Thank you. So, very few times I would say. One incident early on, when I just moved from Delhi to Udaipur to start the clinics, we had already started the clinic in the sense we had taken over the premises, started renovation, etc. And spent some money in the first clinic construction. And I was still in Delhi, but I would come often. It was last few months of my shifting. And one day when I came here, I came to know that community people have gathered around the clinic and they're saying, you stop the construction renovation work. We won't let you start the clinic here. And I said, this is crazy. They should be all indebted to me that, you're coming from Delhi, a doctor from Delhi coming to such a remote area, and what is the problem? And that kind of, kind of disrupted my, I'd never faced something like this in my life. And but the good thing is that we had friends who came from the similar communities, tried to understand. And the issue was that there was a temple right in front of the clinic where a goddess is prayed. And they said if you do deliveries, the blood that passes is an unclean blood and you can't do it in front of the temple. And you would need to sacrifice a goat to actually then we can allow you to do that. So we sacrificed a goat along with them, and then it went on. So that was one time when I got a bit shattered. I said, why? What is this happening? And the other time was, frankly speaking, was around the COVID time when we continued our clinics throughout the COVID. There was not a single day that when we stopped the clinics, because there's no other service, no PHC, CHC district hospital was running. We said we need to continue working, and we took measures to ensure that staff is safe, but the clinics were running. And we were so busy trying to run the clinics in a difficult situation, keeping the staff motivated. And suddenly we realized that the funding is dried up. And that was the time when for a month or so, I felt that, this is not right. We are trying to stay afloat and somebody needs to come up. But then as usual, it eased off after a month. So these were the two things, two times I would think that it helps. But ultimately I think a lot of when you work with team and there's so many other people working alongside you with as much commitment, then it never a problem that you can't surmount.
Sir, you have been graduated and post-graduated from medical college and having vast experience in UNICEF and in the community. We are having medical college and we are providing lot of exposure to the community area, basic health care. So you must be in a position to identify the gap in a medical college, which actually we should try to fill it up. So what are those gaps, you think?
So, I can't straight away answer this for this medical college because I know that several steps are taken and it is a value and a service driven organization. But within that, there may be operational issues which can be done differently or more can be done to ensure that children get exposure. In general, in most other medical colleges that I have seen, what you see is what you learn. And therefore, what you see is often not a service orientation. What you see is often a lot of commercialization of health. What you see is a lot of, you don't see empathy. You see a lot of high-handedness in the way people are treated or disrespectfully treated. I don't know whether some of you might have seen studies from UP a couple of years back, and many of you would know also from your friends and colleagues. In medical colleges, women being slapped while in labor to push and to, all of that. So that kind of a disrespect, if you see, of course, students would not be. In fact, in one of our rural sensitization program, a young graduate from a medical college in Delhi, she said that our professors say that, forget about this empathy, you just learn what you need to do, all this distracts. So, I think that's where we need to do much, much better as a society of medical educationists to promote those values. Specifically, one can look at ways to create certain programs in which the exposure is much. I think one of the problems is, as I think someone was talking also about the district, what is it called? The district exposure program. DRP. I think a lot of problems many times is that there is nobody to guide you there. You're left alone as a single person in a vast, corrupt and often inefficient system. And you don't know, you are lost in that. And so somebody needs to be there to help you navigate that process. That's where many of these well-meaning programs fail, because You don't understand that a young person at 21, 22, when he sees everybody around you, nobody is taking care of you. Sometimes when people in RSP again and in other interns that come to us, they say, I don't know why you are taking us so seriously. Nobody takes us so seriously. So, so because we believe in them, we think that they are the most critical people and they need to be supported. They have all kinds of questions and confusions in their mind because their messages come from various places. So I think you need to give them that time to understand, explore their own minds and the world around them. So I think that's where it's not only technically saying that you go and work there and that will change your perspectives. You need to, when you're thrown there, you also have many more questions and somebody needs to be there to answer or help them find answers.
Um, What an inspiring and deeply insightful lecture, sir. Right? You've not just given a diagnosis of the problem, but a compelling roadmap for the solution. To express our deep gratitude and esteem, we would like to felicitate Dr. Pavitra Mohan. May I request Shri Amit Patel to honor Dr. Pavitra Mohan with a shawl. May I request Sri Jagrut Bhatt to present a small keepsake, a memento of our deep appreciation. Thank you, sir. Memorable maulings like this are the result of efforts of many people working behind the scenes. To formally thank our chief guest, our dignitaries and all of you present here today, may I now invite Dr. Swapnil Agarwal, Dean, Pramukh Swami Medical College, to deliver the vote of thanks.
I am privileged to deliver the vote of thanks on this 20th H.M. Patel Memorial Lecture. It is gratifying to realize that the purpose for which this lecture series was considered is being fulfilled every year with the same commitment and optimism. Our students, faculties and healthcare professionals, they get inspiration and a gist of the phenomenal journeys of stalwarts who have dedicated their lives the field of healthcare with their heads and souls. We have been fortunate to have stellar personalities like Dr. John Omencherian, Dr. Abhay Bang, Dr. Ravi Kannan to name a few. On behalf of the institution, I am grateful to our speaker for the day, Dr. Pavitra Mohan, co-founder and executive director, Basic Healthcare Services, who accepted our invitation to grace the occasion. Sir, we are really honored to have you here. Your work in the southern districts of Rajasthan has been an inspiration to all, and it motivates us to continue doing good work for those who need healthcare services at an affordable cost. I wish to thank our chairman, Shri Atul Patel, who could not be here today, our president, Dr. Gauri Trivedi, our secretary, Shri Amit Patel, our provost, Dr. Abhay Dharamsi, and the registrar, Dr. Jyoti Tiwari, for their support in holding this memorial lecture. My sincere thanks to all the invitees, heads of institutions, faculty, staff, and students who have graced the occasion. We have good number of students sitting upstairs who have had this session live to witness. I thank all the press, the media members present here for covering the event and appreciate their continued support to the institute. Before I end, I wish to mention the team of staff at the Bhikhabhai University, office, the corporate communications, HR&A department, hospitality, housekeeping, security, maintenance, and a host of other services for their tireless efforts in seeing this lecture a success. Thank you all.
Thank you, Dr. Agarwal. This brings us to the close of the 20th H.M. Patel Memorial Lecture. May I now request everyone to kindly rise for the national anthem.
अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंधु गुजरात मराठा द्राविड़ उत्कल गंगा विंध्य हिमाचल यमुना गंगा उच्छल जलधि तरंगा तब शुभ नामे जागे तब शुभ आशीष मांगे गाहे तब जय गाथा जन गण मंगल दायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
Jai. 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 Thank you all. High tea is now arranged for all the guests.